Respected my teacher and my student. Today I will talk about eco-evaluation of prosthetic heart valve. Before you have to do for prosthetic heart valve eco-evaluation, you have some knowledge of the type and pattern of prosthetic heart valve, which is available for in your lab. So there is type. First of all, there is some types of prosthetic heart valve, especially the mechanical heart valve, then bioprosthetic heart valve, and now recently the TAVI. So in case of mechanical heart valve, there is some older generation valve and some young generation valve. This is the older generation Starr Edward valve. Another name is ball and cage valve. Now this is the ball, that is celestic ball, and this is the cage. It is not used. It was used before 80s because there is some sort of complication of this valve more than other types of valve. So this is not now used at it, but before 80s it was used. And then single leaflet tilting disc valve. This is single leaflet tilting disc valve, and it is another name is Madronic Hulk valve. There is single disc and it is tilted, and there is two orifice. It is a single leaflet tilting disc valve. And most commonly used valve is this one, that is bileaflet tilting disc valve. It's St. bileaflet tilting disc valve. You easily appreciate this by there is two leaflet, 1 and 2, and 3 orifice in middle one and side 2 orifice. So it is bileaflet tilting disc valve. And this one is the bioprosthesis valve. It is important to know about the anatomy and of this valve, because when you image the valve, you have to know the anatomy, because by anatomical identification of the valve as well as their hemodynamic profile in vitro as well as in vivo, because hemodynamic profile varies these two valves and these three valves also. And this is the prosthetic heart valve, and this is the mechanical commonly used valve, St. bileaflet valve. Prosthetic heart valve, there is various types of prosthetic heart valve. One is the genograft, that is commonly used valve is genograft. It is, and another is autograft and homograft. Already you know this autograft is the same patient valve is implanted from one side to another side, like Ross procedure. And autograft is the cadaveric valve, sometimes used from cadaver, cryopreserved valve. And most commonly used valve is genograft. It is porcine derivative and that is stented. There are some cases of metallic stent also in genograft. There is biological valve. It is last 8 to 10 years. No anticoagulation is required. It is a very important one. Anticoagulation is not required for lifelong. Its advantage, and there is no click. It is also important because there is no metallic sound or click, and in comparison with this mechanical valve, there is click, and sometimes patient bother of click because when the patient goes to sleep, there is some metallic sound, particularly older generation valve, that creates some problem for patient lifestyle. And this mechanical valve usually lasts more than 20 to 30 years, but main disadvantage is lifelong anticoagulation. Before you do an imaging of the prosthetic heart valve, you have to have some background knowledge of this patient, particularly name, age, and hospital number. It's so that the misidentification cannot be happen. Another is height and weight of the patient. Is very important in case of prosthetic valve evaluation. Height and weight of the patient, date of surgery, before when it was implanted, what type of valve is implanted, because patient various type has various hemodynamic profile. Baseline postoperative echo and serial number. This is very important. Baseline postoperative echo. because the baseline post-operative echo will tell you the how valve is working. Usually, after implantation of metallic or prosthetic valve, particularly metallic valve, the in hospital before discharge there was an echo is done before discharge, one echo. Then after first visit of the clinic, then do another echo, and after 4 to 6 weeks, when hemodynamic profile of the patient settle after a big operation, then another echo is done. This 3 echo is very important for subsequent follow-up of the patient. And you have to know that the patient is whether they properly anticoagulated or not, adherence to anticoagulation, and before doing an echo, the history of anticoagulation taking, and particularly if needed, the INR level should be measured in case of metallic prosthetic heart valve. And symptom, why the patient is going for imaging study, is there any symptom or not, and which type of symptom. Any suggestion of high cardiac output state, is there a patient has fever, anemia, thyroidosis, or pregnancy, because high output state causes some sort of derailment of hemodynamic profile, and prosthetic valve evaluation hemodynamic profile is very important to detect whether the valve is stenotic or not. So this parameter is very essential before going for imaging of a prosthetic valve. Now, first thing is that all prosthetic valve have some amount of obstruction. You bear in mind that all prosthetic valve have some sort of obstruction. It is very important lesson that all prosthetic valve have some sort of obstruction. Now, as there is stenotic, it has some regurgitant effect also. So there are some physiological regurgitation in all prosthetic valve. Bear in mind that there is some physiological regurgitation of all prosthetic valve. Sometimes it is causing volume, some author causing it washing jet or washing jet phenomenon, and there is some parameter how much regurgitation is physiological. In case of ball and cage valve, that is older generation valve, it is 2 to 6 milliliter, and single tilting disc it is 5 to 9 millimeter, and bileaflet disc it is 5 to 10 millimeter, and biprosthetic valve there is very negligible regurgitation, less than 1 millimeter. Already you have said this is the bileaflet disc, there is 3 orifice and there is regurgitation from 3 orifice. It is a physiological regurgitation, and it is the tilting disc valve, there is single regurgitant orifice, and physiological this is, and this is ball and cage valve, there is some sort of regurgitation also. Now, physiological prosthetic regurgitation flow typically has regurgitant jet area less than 2 cm square and jet length less than 2.5 cm in mitral position, jet area less than 1 cm square and jet length less than 1.5 cm in aortic position. This is physiological regurgitation. Above this, you will assume that there is pathological regurgitation. And one thing is that the regurgitation is, you have to appreciate the jet, from where jet is coming. Is it from central or it is from the peripheral jet? Peripheral jet, eccentric jet, mostly due to paravalvular leakage. So paravalvular leakage, you have to carefully look for whether it is physiological regurgitation or paravalvular leakage. Pathology you should look for evaluation of prosthetic heart valve. Which pathology you will look for? One thing is first important whether it is stenotic valve or there is obstruction. Another is regurgitant or paravalvular leak. Third, is there valve dehiscence? Is there any sign of infective endocarditis? And whether the patient prosthetic mismatch occur. Now we will look one by one for evaluation. For evaluation of prosthetic heart valve by thoracic echo, it is more challenging because transthoracic echo is not so clear for evaluation of prosthetic heart valve because there is lots of reverberation artifact as well as acoustic shadow in particularly mechanical prosthetic heart valve. So you have to use multiple windows, some atypical windows and some sort of modified echo window you have to use for proper evaluation of prosthetic heart valve. Now, imaging of the valve, you have to look for motion of the cuffs, the leaflet and occluder. There is prosthetic valve, there is occluder, we usually call occluder. By prosthetic valve, we call some cuffs or leaflet. So occluder movement, whether occluder, two occluder or single occluder is moving well or not, it is very important. If one leaflet is not moving, you should carefully look for whether movement is normal or not. Presence of calcification or other abnormal structure on various components of the prosthesis. You also look for valve sewing ring integrity and motion. The valve sewing ring, you already know that valve sewing ring is the where valve is attached. It is a sewing ring. Surgeon sewing the valve. This ring is very important whether it is intact or not. It can determine the motion of the valve, whether valve motion is base of the valve motion is normal or not. Now, then you have to assess by Doppler assessment of the valve. Which Doppler? Spectral Doppler envelope. You have to see the contour of the spectral Doppler envelope. By looking the contour of the spectral Doppler environment, you can assess some sort of pathology, whether there is stenosis or not. Peak velocity and gradient, mean pressure gradient, Doppler signal velocity time integral, this is also called VTI, velocity time integral, velocity Doppler velocity index, pressure half time, effective orifice area, presence, location and severity of regurgitation. So Doppler assessment of these findings parameter you have to look for one by one. One is Doppler envelope, peak velocity and gradient, mean pressure gradient, velocity time integral, Doppler velocity index, pressure half time, effective orifice area, presence, location and severity of regurgitation. Other imaging data they can help you, that is the LB and RB size, function, hypertrophy, LA and RA size, coexistent valvular, other valvular disease, and estimation of pulmonary artery pressure. Previous post-operative study, already I mentioned you that previous post-operative study is very important, serial echocardiography to assess the prosthetic heart valve, how it works. Now, very important findings of prosthetic heart valve is particularly the stenosis. There are two pathology causes stenotic prosthetic heart valve. One is thrombus, another is penas. You have to decide if there is any stenosis or there is whether it is due to penas formation or thrombus formation. The pathology is different. Thrombus is one thing and penas is another thing. Thrombus, you already know, thrombus form any foreign body can causes thrombus in our body. So metallic heart valve is a thrombogenic, you know. So there can be a thrombus function. For this, to prevent thrombus, we are putting the patient into anticoagulation. So thrombus formation or penas formation, and thrombus usually form in the occluder or the central part of the valve. In the central part of the valve, thrombus is formed and it is attached to the occluder, and thrombus has some sort of movement, thrombus. But in case of penas, penas is the fibrous tissue outgrowth. It's formed in the side of the sewing ring, in the side of the valve is the penas, and it is highly echogenic. It is the more echogenic than thrombus, and it is not in the central position. It is the peripheral position of the valve ring. In the side of the valve ring, there is excess fibrous tissue formation, causes valve to narrow and causes valve stenosis. So penas and thrombus. Another thing is the rate of onset. Thrombus is the acute or subacute onset. So there is rapid deterioration of the patient hemodynamic profile and patient symptom. But venous formation, it is the slower process. So it's formed very slowly. Around 6 months to years, more than years, it is required for venous formation to cause obstruction of a valve. But thrombus, it is within few weeks or even some days if they can form a thrombus or this valve stenosis. Now, spectral Doppler jet. You have to first look for spectral Doppler jet, the contour of the jet. What is normal or abnormal? It is in case of it is the aortic valvular spectral Doppler. It is a triangular and it is early peaking. It is a normal. It is an early peaking jet and it is triangular. It is a normal. But if it is the look like this is the rounded and the peaking is late peaking and it may be more late peaking. The more the stenosis, the more the late peaking of the spectral Doppler jet. So you can assess or you will think that there might be some sort of stenosis. So by looking the spectral Doppler jet, you can assume whether there is stenosis is not. Now, acceleration time and ejection time. The spectral Doppler acceleration time and ejection time. The acceleration time is this one is the acceleration time. How long it is required to eject the blood. This is the acceleration time. And ejection time, there is the maximum ejection. There is the maximum ejection. This is the ejection time. This is the ejection time. It is the AT and ejection time. So I already mentioned that the acceleration time will also prolong and ejection time will also prolong in case of stenotic valve. Now, Doppler velocity index. You have to assess Doppler velocity index. What is Doppler velocity index? Doppler velocity index is the dimensionless ratio of the left ventricular outflow tract by pulse wave Doppler to the velocity by the continuous wave Doppler across the aortic prosthesis. It also goes BTI may be used instead. The Doppler velocity index is the BTI, velocity time integral of left ventricular outflow tract. It is done by pulse wave Doppler divided by BTI of aortic valve. It is done by continuous wave Doppler. In case of it is the equation of aortic valve. So Doppler velocity index of aortic prosthetic heart valve. If it is more than 0.30, it is normal. If it is between 0.25 to 0.29, there is sort of possibility of some sort of stenosis. If it is less than 2.25, there is some sort of stenosis. So by simple measurement of DBI, you can assess whether the patient valve is stenotic or not. It is the aortic valvular. In case of aortic valvular. Now, how we will assess the mitral valve? The DBI, Doppler velocity index of mitral valve, is calculated by BTI of mitral valve. It is done by the continuous wave Doppler and continuous wave Doppler divided by BTI of LVOT. It is done by pulse wave Doppler. So DBI of this in case of mitral valve, if it is less than 2.2, it is normal. 2.2 to 2.5 is there is maybe a possibility of stenosis, and more than 2.5 is normal. Now, effective orifice area. What do you mean by effective orifice area? Effective orifice area is varies between the valve to valve. Which type of valve is implanted depends on effective orifice area. In case of bioprosthetic valve, the effective orifice area is more because there is central rounded area of orifice. It is more. But in case of mechanical valve, as there is two start, usually it is Sandru's bilateral valve, the effective orifice area will be reduced, and there is three compartments, two lateral and one central. These three compartments adding the effective orifice area. So we also can calculate the effective orifice area. How we can do it? Effective orifice area. The calculation of effective orifice area of a prosthetic heart valve is done using the continuity equation, similar to what applied to native valve. Continuity equation, you already know how can we measure continuity equation. Is the same equation which we were using for native valve. Effective orifice area of aortic prosthetic heart valve is the cross-sectional area of LVOT into BTI of LVOT divided by BTI of aortic valve. The cross-sectional of LVOT, I already know that, is pi r square, and BTI of LVOT, it is done by pulse wave Doppler, and BTI of aortic valve, it is done by continuous wave Doppler. And effective orifice area of mitral prosthetic heart valve is again cross-sectional area of LVOT into BTI of LVOT divided by BTI of mitral valve. BTI of LVOT is done by pulse wave Doppler, BTI of mitral valve is done by continuous wave Doppler. And cross-sectional area, again, it is pi r square. Pi is the constant one, r square is radius into square. So by these two calculations, we can get effective orifice area. Now, continuity equation is invalid or inadequate when there is concomitant moderate or severe mitral or aortic regurgitation. If you look that there is severe mitral or moderate to severe mitral or aortic regurgitation, you cannot use continuity equation. You should look for other parameter. So effective orifice area by continuity equation is invalid if there is any moderate to severe regurgitation. Now, pressure half time. Unlike the native valve, the concept of pressure half time has not been validated for effective orifice area calculation of a mitral prosthetic heart valve. So pressure half time is not useful in case of prosthetic heart valve evaluation. But significantly prolonged pressure half time, if it is more than 200 milliseconds, it may suggestive of there is stenotic prosthetic heart valve. Now look for the parameter of assessment of aortic prosthetic heart valve, Doppler parameter. First, you look for jet contour, whether it is triangular, early peaking, normal. If it is intermediate, it may be possibility of stenosis. It is rounded and symmetrical, suggestive of stenosis. Next, look for peak velocity. If it is the peak velocity, meter per second, less than 3, normal, 3 to 4, possible stenosis, more than 4, suggestive of stenosis. Mean gradient less than 20 millimeter of mercury is normal, 20 to 35, possibility of stenosis. If it is more than 35, there is stenosis. Effective orifice area more than 1.2, normal, 0.8 to 1.2 is possibility of stenosis. If less than 8.8, it is suggestive of stenosis. Doppler velocity index, if it is more than 0.30, is normal, 0.25 to 0.29 is possibility of stenosis, and if it is less than 0.25, that is suggestive of stenosis. Acceleration time 80, less than 80 millisecond, normal, 80 to 100 millisecond, possibility of stenosis, and more than 100 millisecond, suggestive of stenosis. One thing bear in mind that these all parameter you should look for and then assess and comment about your valve, prosthetic valve. Not all parameter will fit in a patient. You have to judge by all parameter, and then you have to judge whether there is stenosis or not. After judging the all parameter, and all parameter does not in the same line. So your judgment, final judgment is the final report of your echo. Next, mitral prosthetic heart valve Doppler parameter. Mitral prosthetic valve, you have to look for peak velocity. If it is less than 1.9, normal, is 1.9 to 2.5, possibility of stenosis. More than 2.5 is suggestive of stenosis. Mean gradient less than 5 is normal. 6 to 10 is possibility of stenosis. More than 10 is suggestive of stenosis. Effective orifice area, if it is more than 2.2 is normal. 1 to 2 is possibility, and less than 1 is suggestive of stenosis. Doppler velocity index less than 2.2 normal, 2.2 to 2.5 possibility of stenosis, and more than 2.5 is suggestive of stenosis. Pressure half time, if it is more than 200, there is suggestive of stenosis. Again, you have to look for every parameter, and after judging every parameter, you will make final comment about the valve stenosis or not. Now, Another easy way to assess a mechanical prosthetic heart valve, I am mentioning mechanical prosthetic heart valve. Another easy way for some sort of assessment is cinefluoroscopy. Take the patient into the cath lab and just open the cinefluoroscopy. You can appreciate a very good view of the leaflet occluder, whether the occluder is moving well or not. If the occluder is moving well, there is less chance of stenosis, particularly formation of the thrombus. It is useful for assessing mechanical prosthetic valve. Mitral prosthesis is best visualized from areocranial projection, and aortic prosthesis can be viewed from areocaudal or aleocranial projection. Now look at this. This is the bileaflet St. mechanical heart valve. There is two occluder. This one is one, and that one is another. The two occluder. In cinefluoroscopy, you have to look for this two occluder is moving well or not. If one or two occluder, both occluder is not moving well, then there is suggestive of stenosis or valve malfunction, either by thrombus or venous outgrowth. Let's see. Look, this is a very nice. This is a very nice valve. This two occluder is moving, so there is. We can assume that valve is properly functioning. It is the easy way of to assess the valve. Now, valve dehiscence. Dehiscence, detachment of the sewing ring from the annulus may occur in the early postoperative period because of poor surgical technique, excessive annular calcification, or chronic steroid use or infection. Infection, the poor surgical technique, particularly poor surgical technique and infection is very important in early surgical period to make a valve dehiscence. Late dehiscence occur mainly from the infective endocarditis. Abnormal locking movement of the prosthesis is indication for urgent surgery. So if the valve, base of the valve is moving abnormally, locking movement, that is suggests that the valve is dehiscence. Now, endocarditis. Approximately 3 to 6% of patients will experience prosthetic valve endocarditis. Early, less than 60 days, most likely Staphylococcus epidermidis, that is the culprit organism, and late, similar to the community acquired native valve endocarditis. Transthoracic echo is not good modality to detect endocarditis. Transesophageal echo is a choice to detect endocarditis because sensitivity and specificity is very high in comparison with transthoracic echo. Now, you have to, already I have said that you have to assess for also paravalvular regurgitation. These are the parameters to assess paravalvular regurgitation. Lots of parameters to assess paravalvular regurgitation, but most of these parameters are the same as native valve regurgitation. First, you have to look for the regurgitation jet, whether it is central or eccentric. If eccentric, that is the paravalvular leak, you have to carefully zoom the echo and look for the from where the regurgitant blood coming from. It is, if it is beyond the sewing ring, it is definitely paravalvular leakage. In case of, you have to early referral to the surgical unit for paravalvular repair. This is aortic position. Okay. Now, patient prosthetic mismatch. What is this? Patient prosthetic mismatch is assessed by the calculating the index effective orifice area, which is effective orifice area of the prosthetic divided by the patient body surface area. Index effective orifice area. Now, patient prosthetic mismatch. That is, if you implant a prosthetic, there is a various size of prosthetic because every patient's body size is not same. We have different size of the body as our weight, our height is varies according to patient to patient. So if you put a smaller valve in a big size patient, then definitely patient prosthetic mismatch occur and it will give you the stenotic valve. Valve is normal, everything is normal, but patient will experience some sort of symptom of stenotic valve because you are putting the smaller size into a bigger patient. This is called patient prosthetic mismatch. So To avoid patient prosthetic mismatch, before surgery, you have to do a good echocardiography and you have to mention the which type of valve and which size of valve is fit for this patient. There is some sort of equation and parameter so that surgeon can take the proper size of the valve and implant proper size of the valve to the proper patient to avoid patient prosthetic mismatch. Otherwise, after successful operation, the patient symptom will be more or patient will be symptomatic and redo surgery will be necessary. Now, how will assess the patient prosthetic mismatch? There is the index effective orifice area. There is the effective orifice area. Already you know the calculation of effective orifice area and divided by the patient body surface area. Now look at the table. Is aortic prosthetic heart valve. Patient prosthetic mismatch. It is the index effective orifice area more than 8.5 centimeter square per meter square body surface area. It is insignificant. If it is less than 0.65 centimeter square per meter square of body surface area, it is severe patient prosthetic mismatch. Patient will experience stenotic valve symptom. If it is 0.65 to 0.85 centimeter square per meter square, it is moderate patient prosthetic mismatch. It is the aortic valve. In case of mitral valve, that is, if index effective orifice area more than 1.2 centimeter square per meter square, it is insignificant. If it is less than 0.9 centimeter square per meter square body surface area, it is severe. And between these two, it is moderate. Now, prevalence of patient prosthetic mismatch after aortic valve. There is a study how prevalent of patient prosthetic mismatch. There is moderate patient prosthetic mismatch is 20 to 70%, and severe prosthetic mismatch is 2 to 20%. Why patient prosthetic mismatch is important? It is associated with 1 to 2-fold increase in the risk of mortality and heart failure and rehospitalization. Reduced effort in tolerance causes faster structural degeneration of the bioprosthetic valve following surgical aortic valve repair. Vulnerable subset. Avoid any patient prosthetic mismatch. Who should avoid the patient prosthetic mismatch? Because this patient should be properly evaluated before surgery to avoid patient prosthetic mismatch. Those who have pre-existing LV dysfunction, those who have severe left ventricular hypertrophy, concomitant mitral regurgitation, classical or paradoxical low flow, low gradient aortic stenosis, and those whose age less than 65 to 70 years of age. These patients should be properly evaluated before putting any prosthesis to avoid patient prosthetic mismatch. Prevention of patient prosthetic mismatch, implanting a newer generation of prosthetic valve with better hemodynamics. Enlarging the aortic root or annulus to accommodate a larger prosthetic valve. You have to do the larger prosthetic valve as much as we can accommodate the larger prosthetic valve is to avoid the patient prosthetic mismatch. Performing transcatheter aortic valve replacement rather than surgical aortic valve replacement is one option to avoid patient prosthetic mismatch, because TAVI it can be balloon expandable, higher implant depth, and post dilation. We can do post dilation in case of TAVI. Now it is the flow chart for anticoagulation of the patient prosthetic mismatch. Already you know mechanical valve and bioprosthetic valve, how you will anticoagulate this valve to function properly to avoid thrombus formation. How to identify bioprosthetic valve thrombosis? Bioprosthetic valve, it can be thrombus. More than 50% increase in the mean gradient of our post-implant value. Post-implant value more than 50% mean gradient. Increase cuff thickness plus minus layered thrombus seen in the cuffs. Most commonly on the downstream side. Decrease cuff mobility. If there is atrial fibrillation and subtherapeutic INR, trans-esophageal echo recommended in abnormal transthoracic echo. If transective is equivocal, then CT may be helpful to detect bioprosthetic valve thrombosis. Thank you.
Thank you, sir, for nice class, sir.
আপনারা যদি কোনো কোয়েশ্চেন থাকে বলতে পারেন।
আদার স্যার,
হ্যাঁ
স্যার আপনি যে স্যার সুন্দরভাবে বলছেন স্যার সবগুলো জিনিসই, ক্লিনিক্যালি স্যার আমরা স্যার যে প্র্যাকটিস করতেছি আমাদের হয়তো ট্রান্সপ্লাসিভ ইকো হচ্ছে। ট্রান্সপ্লাসিভ ইকো দ্বারা স্যার আমরা সহজভাবে কোন কোন পয়েন্টকে হাইলাইট করে আমরা মোটামুটি বুঝতে পারি।
হ্যাঁ, আমি যে যে কথাগুলো বললাম সবগুলো ট্রান্সপ্লাসিভ ইকো দিয়ে করবেন। যে পয়েন্টগুলো দেখালাম আপনাকে, ডপলার ভেলোসিটি ইন্ডেক্স, ভেলোসিটি টাইম ইন্টিগ্রাল, এফেক্টিভ ওরিফিস এরিয়া, এভরিথিং ইজ পসিবল বাই ডুইং ট্রান্সথোরাসিক ইকো, which you need some sort of experience. Everything is possible by transthoracic echo, which already I mentioned. বুঝতে পারছেন? এটা ট্রান্সথোরাসিক ইকোরই মানে আপনার যে আমি যে জিনিসগুলো দেখালাম সবগুলো ট্রান্সথোরাসিক ইকো ফাইন্ডিং।
Hiranmoy, thank you for your nice, elaborate and concise presentation. খুব সুন্দর এবং ভালো লাগলো। আমার একটা কোয়েরি, যেহেতু কোশ্চেন কম আসতেছে, একটু এদিকে করুন। ধরো ইয়াং পেশেন্ট, আমরা তো মেকানিক্যাল প্রস্থেটিক ভালভই প্রেফার করবো বিলো 65 ইয়ার্স, তাই না? বাট ইফ দ্য পেশেন্ট ইজ কন্ট্রাইন্ডিকেটেড, পেশেন্ট হ্যাজ কন্ট্রাইন্ডিকেশন ফর অ্যান্টিকোয়াগুলেশন, সেই ক্ষেত্রে মানে আমাদের ডিউরেবিলিটি চিন্তায় এবং তার লাইফ এক্সপেক্টেন্সির চিন্তায় আমাদের অপশনটা কিরকম হইতে পারে? আমরা কি বায়োপ্রস্থেটিক চিন্তা করতে পারি কিনা? কি
হ্যাঁ, পেশেন্টের ইরেসপেক্টিভ অফ এজ, যদি পেশেন্টের যদি অ্যান্টিকোয়াগুলেশন ইজ কন্ট্রাইন্ডিকেটেড থাকে, ব্লিডিং রিস্ক থাকে, অর পেশেন্ট হ্যাজ ব্লিডিং ডিসঅর্ডার, দেন আমরা অবশ্যই 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 তাকে বায়োপ্রস্থেটিক ভালভ দেব।
সেই ক্ষেত্রে রিপিটেডলি আমাদের যদি বদলানো লাগে আমরা বদলাবো।
হ্যাঁ, অফ কোর্স, যদি তার রিডিউ সার্জারি আগামীতে 8 to 10 ইয়ার্স পরে করতে হয় তাহলে করতে হবে। কিন্তু যদি কন্ট্রাইন্ডিকেশন টু ব্লিডিং থাকে, মানে অ্যান্টিকোয়াগুলেশন থাকে, তাহলে আমরা বায়োপ্রস্থেটিক ভালভ ইউজ করব। পরবর্তীতে আমরা যখন প্রয়োজন হবে আমরা আবার রিডিউ সার্জারি করব।
আচ্ছা, আর চাইল্ড বিয়ারিং এজের যদি ওমেন হয়,
চাইল্ড বিয়ারিং এজের ওমেনে এটা হলো শেয়ার ডিসিশন, মানে ডিসিশনটা নিতে হবে শেয়ার করে, যে পেশেন্টের সাথে এবং আমাদের যে ডক্টর থাকবেন ওনারা মানে হার্ট টিম, সেটা ডক্টরের সাথে শেয়ার করবেন যে আপনি চাইল্ড বিয়ারিং এজে আপনার ফ্যামিলি কমপ্লিট না, আপনাকে ভালো রিপ্লেস করতে হবে। এখন আপনার দুইটা অপশন, একটা হলো যে আপনি যদি মেকানিক্যাল ভালভ আপনি দেই, সেই ভালভটা দূরে মানে আপনার লাইফ লং অ্যান্টিকোয়াগুলেশন লাগবে, সেই ক্ষেত্রে দেয়ার ইজ সাম সর্ট অফ রিস্ক থাকবে আপনার বেবির উপরে। রিস্কটা বলতে হবে যে কতটুকু রিস্ক, আপনি এই ওষুধটা খেতে হবে অ্যান্টিকোয়াগুলেন্ট, এবং সেটা কিছুটা রিস্ক আপনার বেবির উপরে থাকবে। সেটা আপনি যদি মেনে নেন তাহলে মানে মেকানিক্যাল ভালভ ইউজ করবেন। যদি পেশেন্ট বলে না আমি কোনো রিস্ক নিতে চাই না আমার বেবির উপরে, আমার উপরে আপনি রিস্ক নিব, যদি রিডিউ সার্জারি করতে হয় তাহলে করবো, তাহলে পেশেন্টের প্রেফারেন্সে তাকে আমরা বায়োপ্রস্থেটিক ভালভ দিব। A shared decision making after knowing every pros and cons of the anticoagulation and mechanical and prosthetic valve. Then patient will choose the which type of valve he wants.
Thank you very much.
স্যার আদাব স্যার।
হ্যাঁ
স্যার, এই যে প্রস্থেটিক ভালভ ডেহিসেন্স বললেন, ওটা কতদিন টাইম পর্যন্ত হইতে পারে স্যার? ওটা কি আর্লি কমপ্লিকেশন নাকি লেট কমপ্লিকেশন?
হ্যাঁ, প্রস্থেটিক ভালভ ডেহিসেন্স আর্লি হইতে পারে, লেট হইতে পারে। আর্লি সাধারণত হয় যদি ইনএডুকেট প্রপার সার্জিক্যাল টেকনিক না হয়। প্রস্থেটিক বা ডেহিসেন্স বাংলায় বলতে গেলে ভালভটা যেখান থেকে আপনার এই যে সুইং করা হয়েছে মানে লাগানো হয়েছে সেখানে থেকে ভালভটা ছুটে গেছে, কিছুটা ছুটে গেছে বাংলা কথা বলতে গেলে, এটা বলে ডেহিসেন্স। তো যদি প্রপার সার্জিক্যাল টেকনিক না হয়, সুইং যদি ভালো না হয়, অথবা যে জায়গাতে সার্জন সুইং করছেন সেই জায়গাটাতে হয়তো কোনো ইনফেকশন ছিল অথবা পরবর্তীতে ইনফেকশন ডেভেলপ করে, তাহলে আর্লি সার্জিক্যাল ডেহিসেন্স হবে। আর্লি সার্জিক্যাল ডেহিসেন্স দুইটা কারণে সাধারণত হয়: ফল্টি টেকনিক অফ দ্য সার্জন অ্যান্ড অ্যানাদার ইজ ইনফেকশন, ইনফেক্টিভ এন্ডোকার্ডাইটিস অর প্যারাভালভুলার ইনফেকশন অর অ্যাবসেস ফর্মেশন। অনেক সময় দেখা যায় যে অপারেশনের পরে অ্যাবসেস ফর্মেশন হয়, অ্যাবসেস ফর্মেশন হলেও ভালভ ডেহিসেন্স হতে পারে, এটা আর্লি ডেহিসেন্স। এখন আসেন লেট ডেহিসেন্স। লেট ডেহিসেন্স মেইনলি হয় লাগে আফটার ইনফেক্টিভ এন্ডোকার্ডাইটিস। ইনফেক্টিভ এন্ডোকার্ডাইটিসের পরে লেট ডেহিসেন্স হয়। আপনার 3 to 4 ইয়ার্স বা 5 ইয়ার্স পরেও যদি যে কোনো সময় ইনফেক্টিভ এন্ডোকার্ডাইটিস হলে ভালভ সুইং এ আবার অ্যাবসেস ফর্মেশন হবে, ইনফেকশন হবে এবং ভালভ ডেহিসেন্স হবে।
ধন্যবাদ স্যার।
আদব স্যার,
হুম
স্যার এই যে এই মেকানিক্যাল বাল্ব যেটা, এটাতে তো হেমোলাইটিক অ্যানিমিয়া হয়, তো এর মধ্যে কি স্যার কোনো টাইপের বিষয় আছে যে কোনোটাতে কম হয় বা বেশি হয়?
হ্যাঁ, অফকোর্স। আপনার আমি বলছি যে ওল্ডার জেনারেশন স্টার এডওয়ার্ড ভালভ, যেটা হলো স্টার এডওয়ার্ড ভালভ, দিস অলসো কল্ড দ্য বল এন্ড কেজ ভালভ। সেই ভালভের দুইটা আপনার ডিসঅ্যাডভান্টেজ ছিল। ওয়ান ইজ দ্য থ্রম্বোজেনিসিটি ওয়াজ মোর অ্যান্ড অ্যানাদার ওয়াজ দ্য হেমোলাইটিক অ্যানিমিয়া। স্টার এডওয়ার্ড ভালভে হেমোলাইটিক অ্যানিমিয়া বেশি হয় ইন কম্পারিজন টু সেন্ট্রুস ভালভ, দ্যাট ইজ বাইলিফলেট অর সিঙ্গেল লিফলেট ভালভ। এই কারণে স্টার এডওয়ার্ড ভালভ যেটা, সেটা এখন আর ইউজ করা হয় না, ওয়ার্ল্ডের কোথাও স্টার এডওয়ার্ড ভালভ এখন নাই। তবে আপনি যদি খুব ওল্ডার এজ পিপল পান, অ্যারাউন্ড 100 ইয়ার্স or 90 ইয়ার্স এজ, তাদের যদি ভালভ রিপ্লেসমেন্ট করা থাকে, মেবি স্টার এডওয়ার্ড ভালভ তাদের শরীরে পাওয়া যেতে পারে।
থ্যাংক ইউ স্যার।